So, hi, my name is Pablo Tebas from the hospital of the University of Pennsylvania. And both Bill and I, Dr. Short, who is at my left, will be presenting data on a recent study that was closed by the Safety Monitoring Committee around a few weeks ago. The REPRIEVE study is a study that we did for 7 years. Maybe some of the people listening to this webinar have participated in the study, and there was a signal for effectiveness, and the Data Safety Committee decided to close the study and give the medicine to everybody. I think it's an important study that is going to affect the way we treat everybody with HIV. So every person living with HIV is going to be affected by the results of this study. And it's one of the most important studies I think we have done in HIV since the beginning of antiretroviral therapy. And it's going to change the way moving forward. Without further ado, Dr. Short, who is an associate professor of medicine at the University of Pennsylvania and co-directs the unit, the AIDS clinical trial with me, will start the presentation. And feel free to interrupt or to ask questions at the end of the presentation. So go ahead, Bill.
Great, thank you so much. And thanks everyone for joining. Like we're going to call each other by our first name. So like Pablo said, this is very, very exciting. And actually, the both of us are at a meeting in Washington for the AIDS clinical trial group. This is our meeting week. And we're going to have a whole session dedicated to this this afternoon. So let's get started. So I think everyone on the call should know that, and Dr. Tabas sort of talked about that, improvements in antiretroviral therapy have evolved over time. And because of that, we know that people are living longer, and I'm going to show you some of that data. And, one thing that's important to understand right at the offset is, when you hear people talk about AIDS-related deaths, I know we don't like the word AIDS, but the way things are classified, we sometimes will hear these age-related deaths and versus non-age-related deaths. So I really think that's important to understand before we move into the study, because here we're going to talk about a non-AIDS cause of morbidity and mortality. So when we talk about age-related deaths, we're talking about the things that many of us know. We look through the history. Unfortunately, we still see today in 2023, people are dying. We think a lot of very weird infections. So pneumocystis pneumonia, Kaposi sarcoma, they were some of the original descriptions, even cervical cancer. So these are things we say are age-related. That means they're related to HIV, causing that advanced stage with low CD4 counts, very low rates of, we have very, very high rates of immunosuppression. So that's what we call age-related deaths. However, there's also been a switch now that we have people taking antiretroviral therapy, right? So people are living longer. And what's happening now? People are getting older and they're dying from what we call non-AIDS causes. So what are those things? There are things like heart disease, stroke, diabetes, and a whole host of cancers, right? That's not the purpose of this talk. If you were at the Aging Symposium, I guess it's been almost a month now, we had a whole discussion on this, and these are actually some of the slides from that. But so it's important to differentiate those two types of causes of morbidity and mortality. I love looking at this because I think it speaks to the success we have had in the field of HIV. So this is older data, but if you look back in 1996, and whoever remembers 1996, that was really the advent of what we called back then highly active antiretroviral therapy, or HAART. And that was basically used in two different classes of drugs. So at the time was nucleoside reverse transcriptase inhibitors combined with a protease inhibitor. And what that did is it really brought about changes in the landscape of HIV, and life expectancy started to change. So what you see here in 96 to 99, this is a life expectancy at age 20 was up to, you can see here, 54.4. And what happens over each of these different time periods, you see the rates are growing and growing. So why is that? One, people are living longer. We know antiretrovirals were better. Some of those early drugs were met with a lot of toxicity. So while we had them, they were met with, pancreatitis, neuropathy, horrible, horrible side effects, lipodystrophy. And over time, what's happened with antiretrovirals is they've improved. And that's one thing that the group that we work for or have what we call our network as the AIDS Clinical Trial Group has really done an amazing job of doing, is really streamlining and making modern antiretroviral therapy. So here's the current life expectancy for someone with HIV, and I draw your attention to 2 points. So in green is the general population, and then right underneath that is asymptomatic, and note that's asymptomatic HIV positive patients. And so first thing you notice is we're looking at up into the 80s, right? So it's really, really important to know, if you go back here, we're talking about 60. So even if you were 2006, 2007, when we had a lot of the modern ART, you had 47 to that, you're still talking about 67. We are now up into the 80s, and which is wonderful. But what you note here is this little gap, right? So when I have someone comes in, they're newly diagnosed with HIV, I tell them you have a normal life expectancy, because that's what we see here, right? But there is this little gap. And I think this is where a lot of people don't understand where this gap is coming from. And that's really what I hope to show you in the next couple of slides before we talk about the results of REPRIEVE. Again, I highlight this, and I will be briefly over this. So because of this chain and this sort of little gap we have here, and also going back when we talked about some of the non-AIDS cause, these are the things that are really important to do in the office, right? These are really important to make sure we have targeted cancer screenings, prevention of cardiovascular disease, which is the focus of this presentation, making sure we get vaccinations done, especially things like hepatitis B or HPV. We know they cause cancer. Hepatitis screening, psychiatric, and preventing late diagnosis. Because you remember, if you look at all those graphs, they say asymptomatic, right? So we still have, and we still see, both Pablo and I, patients who are newly diagnosed and they have T cells of 0. We still are seeing them every day in 2023, and we really need to reverse that. So this is a graph of when someone first acquires HIV. I'm not going to walk you through this, but what I think we know is that, antiretrovirals have sort of revolutionized this, right? We no longer watch people unless you don't have access to treatment or you chose not to take treatment. We watch the CD4 count over time go lower and lower and lower till they get to the point where it's really below this 200 mark. And people start developing a lot of symptoms, opportunistic diseases, and then death. Right. So we know antiretrovirals have completely transformed this. And now we know that given antiretrovirals at diagnosis, right, regardless of CD4 count, can sort of change this whole natural history paradigm. But what we have left is, and again, I'm not going to focus too much on it, but we're left with something called immune activation. And this is really relevant to all aspects of care, right? So it's a multifactorial interconnection. So that means your immune system is activated. And while that sounds really great, what you see is it's not always great, right? So here are some of the things that happen. So we have HIV replication that causes immune activation. We have different types of hormones we call interferons, which are your body's own natural antivirals. We have different co-infections. I just talked about this. So you have hepatitis B, hepatitis C, we have human papillomavirus. We have all these other viruses that can cause co-infection, immune activation. We have imbalance of T subsets. Remember, there's a CD4 cells are your T cells or your helper cells. But you also have CD8, which are your suppressors. So if you have an imbalance, you're more suppressed than you are helping. And then finally, we have some damage to the gut that occurs early on in HIV that actually causes what we call microbial translocation, is leakage of bacteria across and into the bloodstream to cause a lot of activation. So what does that mean? So again, many of us think when that sounds like your immune system's activated, this is great news, it's fighting. What it does is it leads to a lot of comorbidities and disease progression. And we don't have really great ways of measuring this, which has been, a problem for us. We have what we call poor man markers. We look at certain ratios. Sometimes we look at, inflammatory rates and all that. But really, we know that all this works together to cause disease progression and also these comorbidities that we see. And these are the common comorbidities. And again, for today's purpose, we're going to focus on cardiovascular disease. So frailty, diabetes, kidney disease, weak bones, osteoporosis, neurocognitive disorders, and then a whole host of cancers that we talked about. So before I turn it over, I just, again, so with that as a background, cardiovascular disease is big. It's always, we always talk about cardiovascular disease in the general population as the #1 killer, right? And there's a lot of things that go into cardiovascular disease, but this is specific to HIV. Your right-hand side, we think of traditional risk factors. When we think about someone with heart disease, we think about smoking, we think about diabetes, we think about eating that beautiful cheeseburger from whether that's McDonald's or Wendy's or Burger King, whatever it is, but it's full of meat and cheese and grease and all the things that make it so good, right? So they're all the things we think about when we think about traditional risk factors. But then again, going around, and I'm going to go sort of counterclockwise, that microbial translocation I talked about that happens in early pathogenesis, that also helps to contribute to that. All these other not bacteria, viruses, these are bacteria, these are the viruses. So cytomegalovirus, these are normal pathogens you have. Then the question about what about antiretroviral toxicity, right? This has been looked at years ago, and now we've switched to better antiretrovirals. We know everyone uses integrase strand transfer inhibitors, but we know there's a subset of people who have weight gain from that. And we know that weight gain transforms into elevated body mass index, diabetes, maybe hypertension, hyperlipidemia, or elevation of your cholesterol. So these things also contribute to heart disease. And then sort of the same things, if you notice here, loss of regulatory cells. This looks like I put the slide from the previous one right on here. And then HIV and then other known factors. All this comes together to produce what we call atherosclerosis, or disease of your vessels in the heart that can actually lead to heart disease. So I think with that as a background, one of the questions we had, and Dr. Tabas will cover it in the next section, is, what can we do to prevent heart disease? So if you go through here, a lot of the things we can't really do, but we can do traditional risk factors. So go back to my original slide. We encourage people to stop smoking. We encourage them to eat a better diet, control their cholesterol, control their diabetes, keep their high blood pressure under control. And so we can do that. But the question came up in the general population, can you prevent this by using certain medications called statins? And, many of you know about them: Lipitor, atorvastatin, pravastatin, Pravachol. So there's a whole series of them, but there was no data in HIV. And what we're going to do now is show you the study that was designed years ago, and then go through the results and show you, as Dr. Tabas mentioned, how this is going to transform and change the field of HIV. I turn it back to you, Pablo.
I think I am on mute.
Yep,
Thank you,
good.
Bill. I hope you guys can see my can you see my pointer? Bill, can you see my pointer? Can you hear me?
Dr. Tobias, I see your pointer.
Oh, sorry. Let me see. Okay, so the first question that is relevant is, oh, I don't know who's controlling the.
I gave you control. You should have control.
Okay, so what did we know before doing this massive study, REPRIEVE? So we knew several things. One, that people with HIV are at higher risk of cardiovascular disease when you compare to the general population. And primarily due to the fact that they have chronic inflammation associated with the HIV infection. This is what Bill had been explaining to you, and probably this is the reason of that gap in life expectancy, that still people without HIV have a little bit, a few years more of life than people without HIV, because that gap exists. And it's probably related to the chronic immune activation associated with HIV. We know that some medicines, that mainly the medicines that we use in the past, are associated with side effects, increased lipid, increased cholesterol, and those side effects associated with the medicines can also increase the cardiovascular risk. Now we have better medicines, integrase inhibitors, that are much clearly less associated with cardiovascular events. And beyond anything, we know that if we control regular risk factors for cardiovascular disease, like diabetes, cholesterol, sugar levels, exercise, a healthy diet, that we reduce the cardiovascular risk. The question, as Bill pointed out, that this study was asking is, if we add a statin, a medicine that lowers the cholesterol in people that have high cholesterol levels, in people with HIV that do not need to take a statin, that they don't have high cholesterol, will we have an impact on cardiovascular events? That's the main question the study was asking. I think, I don't know how to move. So we know that HIV is associated with cardiovascular disease. We know that 60% of the people, when we look at the coronary arteries, they have a plaque. This area on the wall that is not smooth, is rough, and it can precipitate a thrombus, and then a thrombi being created here occlude the blood flow, and that is what leads to a heart attack, a myocardial infarction. So this is the way myocardial infarctions evolve. You first have the plaque, you then have the thrombosis, and then the blood cannot go through, and that produces ischemia in the heart, and the muscle tissue of the heart dies, and that's what precipitates a heart attack. We know people with HIV and people without HIV, they have plaque. And some of the characteristics of the plaque in people living with HIV is unstable. It is more rough and is more prone to develop thrombosis. So these are the kind of things that we knew before starting this REPRIEVE study, and that we wanted to attack to prevent these increased cardiovascular events. Sorry about this, in people with HIV. The main question that the HIV, the REPRIEVE study was asking, wanted to answer is, if we add a statin to prevent cardiovascular events in people with HIV that do not need to take a statin because they don't have high cholesterol, will that decrease the risk of what they call MACE events, major adverse cardiovascular events, MACE? So this is the people that enrolled in the study, and I'm gonna put the next slide, were people with HIV, living with HIV, that have low cardiovascular risk. These are not people that have high lipids or hypertension or diabetes that they need to be taking a statin because they have a very high cardiovascular risk. These were people living with HIV that didn't have high cholesterol, diabetes, they didn't have risk factors that make them that they needed to take a statin. So these are people with low cardiovascular risk. They were screened, and we enrolled a massive number of people. 7,000 people were enrolled in this study. I'm sorry about my slide, because I don't have a very good way to control the slides. So 7,000 people were randomized, half and half of them took placebo, and half of them took a pitavastatin. It's a statin in the same family as atorvastatin, which is Lipitor, or rosuvastatin. Crestor is the other famous. Pitavastatin is a more modern pitavastatin and a more modern statin. And the reason why this particular statin was selected is because it has less interaction. So people didn't have to change their antiretroviral medications or other medications they might be taking when they enter the study, because pitavastatin doesn't have a lot of interactions. But it's similar to other statins that have been used to treat. And then there were a sub-study that we are not going to talk about because the results are still not known. And then we follow the people that were enrolled in the study. We follow them for a long time, up to 7 years. People have been followed. And we look at the primary endpoint. We wanted to look at the incidence of cardiovascular death, heart attacks, angina, so pain, coronary pain, strokes, arterial revascularization, people that needed to have a bypass surgery, and peripheral arterial disease. So people that have claudication, that they have pain on their legs when they walk. So all of these events are cardiovascular events, MACE events, major atherosclerotic cardiovascular events. That's the primary endpoint of the study. And there is a bunch of secondary endpoints because people have seen that giving statins and reducing inflammation might decrease the risk of things like cancers, cognitive decline, and other events. But this particular study, at least in the presentation that we're going to have for the first time this afternoon in our meeting in Washington, look at the incidence of cardiovascular events.
Pablo, just say next slide and I'll forward it for you.
Yeah, can you put the next slide, Bill?
Yep, just say next slide, I'll do it for you.
So the study is a massive study, enrolled people with HIV around the world. So in the US, but there were sites in Africa, sub-Saharan Africa, in India, in Thailand, in Europe, in South America. It enrolled many people with HIV, as you can imagine, in a 7,000 patient study. This is the largest study ever done with people with HIV. So in order to enter the study, you had to have HIV infection. You have to be on antiretroviral therapy. So you have to be taking medicines against HIV and be suppressed. And a CD4 count greater than 100 and older than 40, but younger than 75. No history of cardiovascular disease. No history of cardiovascular disease. And your risk factor for cardiovascular disease, we use a calculator online that tells you what is the chances that you're going to have a heart attack in the next 10 years. And anybody in the call, including myself, can go in and you put your age, you put if you have hypertension, if you have diabetes, if you smoke or not, if you're taking a statin, you put all these things and it tells you what is your risk of having a heart attack in the next 10 years. And if your risk is less than 75, less than 7.5%, these are your goals. So you have to have a 10-year, you have to have low risk in order to enter this study, low risk of cardiovascular events in the future. Less than 7.5 if your LDL was less than 190, or less than 10% if your LDL is the bad cholesterol. So if your level of bad cholesterol was less than 160 and greater than 10, but less than 15 if your LDL was less than 130. Because people that didn't have these, they should be on a statin. They should not have participated in the study. So we didn't want people that needed a statin not to receive a statin. So we wanted people that normally we would have not given them a statin to participate in the study. And we exclude people that were taking statins already. They were taking gemfibrozil, a fibrate, to treat hyperlipidemia, or PCSK9 inhibitors. This is a modern drug that treats hyperlipidemia, or people with decompensated cirrhosis. So the bottom line is we want the people that participated in the study is people that didn't need, according to the current guidelines at that time, didn't need to be on a statin. So yes, the reason to participate in the study was to see if adding those statins, people with HIV would decrease the risk of cardiovascular events. Next slide, Bill. And this is how many people we enrolled, 769 people. And many people were enrolled in ACTG, but as I said before, this was a multinational collaboration. There were studies, people that from Canada, people from other networks, international networks that enroll participants. So this is really a multinational study. Around a third of the people didn't qualify that were screened, did not qualify for the study, but the enrollment at the end was 7,769 people. Okay. Next slide, Bill. The median age was 50. Remember that in order to get into the study, you have to be at least 40 and a maximum of 75 or so. The median age was around 50, which is the median age of HIV, people living with HIV in the US. So the sex at birth, more 69% males, 31% women, 35% white, 41% African or African American, because there was a lot of international component from Sub-Saharan Africa, and around 15% were Asian. And these are people that were doing very well. They had high CD4 count, so the CD4 count was greater than 500 in 5,000 of the 7,000 participants. So, and most of the people have low cardiovascular risk, as we expected, because we wanted to enroll people that didn't have a very high cardiovascular risk, people that didn't need to take statins. So 4.5%, 4% for males, and 1.9% for females. The cardiovascular risk tends to be lower in females than in males. So this also was also expected. And the vast majority of people, they have basically normal levels of bad cholesterol. LDL was 108. So think about the population, very garden variety, people living with HIV, doing well on antiretrovirals, high CD4 count, people age of 50 on average that had normal cholesterol and not very many risk factors for cardiovascular disease. Next slide. This REPRIEVE study has contributed already to a lot of knowledge about HIV and also about comorbidities. So the study has published the baseline characteristics. They have also been a cohort that we have used to follow people, incident cases of COVID-19, because these people were followed very closely. We know how COVID-19 was not more severe in people living with HIV than without HIV based on this study, because we followed these people for 7 years and the COVID pandemic happened in the middle of the study. We were able to follow the number of cases of COVID in this 7,000 cohort and the frequency of complications like admissions to the hospital, pneumonia, or intensive care units. So this study was the study that was allow us to know that COVID-19 is not particularly much more severe in people living with HIV, with well-controlled HIV. If you don't have well-controlled HIV, then it can be more problematic. But if you have well-controlled HIV with a normal CD4 count or a high CD4 count, you're not going to have more complications from COVID-19. And these are examples of papers that have already been presented and published about the REPRIEVE study. But now what I'm going to present to you, well, we don't know all the results yet, is the primary study, the primary endpoint of the study, that is the incidence of cardiovascular events. Next slide. So we have been following people from up to 8 years. If you can see in the figure to the right, you can see that around 6% of the people were followed for 8 years. Most of the people, you can see that were followed between 5 and 6 years. So this is the study has been done over the course of many, many years. And which is important because, I mean, these cardiovascular events takes time to accrue. Next slide. So there was a DSMB in all these studies. There is a data safety monitoring committee that meets periodically every 6 months or every year and they look at the results of the study and they are unblinded. They know this is what happened to the people that got the statin. This is what happened to the people that didn't get the statin. And they analyze the study on an ongoing basis because it's not ethical to continue a study if you know the answer. So as soon as they knew the answer, this DSMB closed the study because they said there is a difference between the people that get the statin and the people that do not get the statin. And so the people that got the statin have less cardiovascular events than the people that did not get the statin. And there was no increased risk of toxicity or associated with the statin. So the DSMB decided to close the study and basically ask us to call everybody that was participating in the study, do a final visit, explain the results of the study, refer them to their doctors to start a statin open label outside of the study, okay? And this is the top line data, which is what we know, and we will not know more until July, when the study will be formally presented in the International AIDS Conference in Brisbane. The study will be presented there, and at that time we will know a much more granular data results. But there was a robust signal for efficacy with a 35% reduction of strokes and heart attacks and surgery for revascularization and peripheral ischemia and cardiac-related death in the study. 35% decrease. So that gap is reduced by at least a third because of this intervention in comparison to placebo. So, and there was also a reduction in mortality, which is, we don't know because they have not separated mortality versus cardiovascular events, but we will hear more in July, and we will have more data suggesting that by using the statin, you reduce the mortality and you close that gap with people without HIV. And the study will be presented soon in the International AIDS Conference in July, and it will be published in the New England Journal at the same time as it's presented in Brisbane. So we will have more information in July. Next slide. This was a study that people were very adherent to the intervention. So people were taking the medicines, more than 90% adherence to the medicines. And 80% of the people were followed for up to 8 years. 8 years of follow-up. There was only 20% lost to follow-up, which is remarkable for a study of this nature. The frequency of adverse events between pitavastatin and the placebo was similar, suggesting that the pitavastatin doesn't have a toxicity associated with it. So it's a safe drug that is not associated with a significant amount of toxicity. And the drug works. It decreased the LDL cholesterol in the people that took the pitavastatin. And that didn't change in the placebo, suggesting that that might be the mechanism why there is a decrease in cardiovascular events in this population. Next slide. So there were no safety concerns. Sometimes statins are associated with muscle aches and myopathy, and there was less than 1% of the people developed this problem, and that required to adjust the dose or withdrew from the study. And there has been an association of statins with an increased risk of diabetes. It was a slightly increase of a risk of diabetes, but it was consistent with what has been seen before. And we use statins in many different clinical scenarios. It's not a reason not to use a statin, but there is a small increase of the risk of diabetes. And there were no issues with liver toxicity or rhabdomyolysis, which has been associated with statins. Next slide. So what are the clinical implications? And this is important. We know that people with HIV have increased risk of MIs. And now, because of this study, we know that there is an intervention that decreases the risk of cardiovascular events. To me, we need to see the results, but to me, this means that we're going to be giving everybody older than 40 with HIV a statin to prevent and decrease the cardiovascular risk. This has not made it to the guidelines yet, but I am sure that it will make it to the guidelines in the near future. So when we treat people with HIV, what we're going to be doing is we're going to give antiretrovirals, an antiviral, and we're going to give an anti-inflammatory statin. The two things together is what is going to be the standard of care in the future. I think we need to see the results, the final results, to understand the implications of that. But that's why the title of the talk is, what is the implications of the REPRIEVE study for everybody living with HIV? Everybody living with HIV in the future will have to be taking those two pills, the antiretrovirals, the ART, and a statin to decrease the cardiovascular risk. So that gap on survival is closed, and we hopefully get into a situation that living with HIV doesn't mean that you're going to have you're going to die younger than if you didn't have HIV. Next slide. This is important for participants, and I don't know if there is anybody participating in REPRIEVE. We are telling people that are in REPRIEVE, we're still not unblinded, so we don't know if they were taking the placebo or the real medicine. We're still telling everybody living that participated in the trial to tell their doctor. We give them a letter and get a prescription for a statin, because I think that's important. Does it has to be pitavastatin? No. It can be rosuvastatin or atorvastatin. It can be other statin in agreement with your doctor. Pitavastatin is the fancy new statin. It's a little bit more expensive. Some insurance companies don't approve. If you can take pitavastatin, it's a nice statin because it doesn't have too many interactions. But if your insurance says you have to take rosuvastatin instead, rosuvastatin probably will have the same benefit as pitavastatin. I think the effect is class related. And we are not unblinded, so we will be unblinded in the fall, and we will tell everybody what they were taking. And the REPRIEVE team has told us to tell all of you, all of the people that participated in REPRIEVE, a big thank you. This is the most important study, I think, that we have done since the beginning of antiretroviral therapy, because it will affect everybody living with HIV, and it's going to improve the quality of what we do, taking care of people living with HIV. And we want to send thank you to everybody that was involved in this trial. We did it because all of you collaborated and were participating in clinical research, and we helped answer this question that was so critical for people with HIV. I think that's the last slide. Maybe there is another one, but this is a picture of the whole team. In the middle, you can see the guy with the tie is Carl Fichtenbaum. He's going to be presenting the slides. And the guy 2 times to the right is Steve Greenspoon, who is the PI of the study, the national PI of the study. And these are different study coordinators from different units in the country, across the globe, taking care of people with HIV that participated in the trial. And thank you very much for hearing to us, and we're open to questions.
Great. Thank you. So I think there's already one question. Thank you. Please keep them coming. If you want, you can come on live. I think you can, but if not, I'm happy to read it. So is there a chance that antiretroviral class will contribute to those who had events?
Yeah, I think there are some classes of drugs that have been associated with increased cholesterol, like protease inhibitors, or in some nucleosides, analog like abacavir was associated with a cardiovascular event. So antiretroviral drugs, particularly the all antiretroviral drugs, can be associated with an increased risk of cardiovascular events. And of course, you have to pick between 2 things, not taking antiretrovirals and then HIV progressing, or taking antiretrovirals. On the balance of things, antiretrovirals are very helpful, including the protease inhibitors, including the drugs that are associated with cardiovascular events. The risk of having complications of HIV and AIDS are much more larger than not taking medicines. But the old medicines were less safe than the current medicines that we have now available. So it is important that you talk with your doctor and your doctor selects a regimen that is associated with less toxicity, and it depends on, for everybody is different. Everybody has a different antiretroviral history, different resistance. So you need to talk and pick the right regimen. And in some cases, that right regimen is a regimen that might be associated with increased cardiovascular risk. And that's why you have to talk with your doctor and maybe consider starting a statin in that case.
All right, there's one I'll take. So it comes from Madeline, who I work with. Hi, Madeline. Thank you for joining. So the question is, any special considerations for people taking statins for people on injectable ART? And it's a great question. So I'll just take a step back. I realized when we were going through this, I probably should have done some introduction to the statins other than just talking about it. But so Pablo mentioned, there's a whole group of statins, and I think pitavastatin that he mentioned that was chosen as the study drug to use in this in REPRIEVE was done because each different class of antiretrovirals has different potential for drug-drug interactions. So, what we typically do and what I do is I keep a interaction marker. It's called the Liverpool app on my phone. And anytime I prescribe any drug, I look it up. And that includes statins. So, it really is going to depend on what statin the person is taking and the antiretroviral regimen. So for injectable antiretrovirals, the good news is no, that different drugs, it's rilpivirine and cabotegravir. It's a non-nucleoside reverse transcriptase inhibitor and an integrase. So the good news is no, there's not many drug-drug interactions there. The big ones to think about are when you have people on a protease inhibitor, and remember the boosters, so ritonavir, and then even some of the integrase, for those who know elvitegravir with cobicistat, Genvoya, Stribild, those drugs. So that cobicistat does the same thing as ritonavir. So you always want to be careful there. And the recommendation is, not that you can't use it. Our general working rule is start low and work up. Whereas, if someone came into the hospital and had an acute myocardial infarction, a atorvastatin, they would give them 80 milligrams right off the bat. Not if you're on a protease inhibitor. You start at 10 and work your way up. So great question, though. Hopefully that answered your question.
Yeah. There are some statins that cannot be used with protease inhibitors, all statins like simvastatin and things like that. But the common ones that we use, like Lipitor or Crestor or pitavastatin, the atorvastatin, rosuvastatin, that's Lipitor and Crestor, you start with a half dose, and then you never go up too high, because when you give a booster, you're going to increase the levels and increase the risk of toxicity. But as Bill said, no interactions with the injectables.
All right, we got a bunch of questions. Good. Keep them coming. All right, so hi, Robert, how are you? Would switching from a boosted protease inhibitor possibly decrease lipids and lower cardiovascular risk? It's a great question. I'll give a short answer, then I'll have Pablo do it. So it depends on the protease inhibitor. So I think a lot of the newer protease inhibitors we use are better. But yes, so if you do switch from certain drugs that are associated with elevated lipids and cholesterol, and I must say, not only it's not only protease inhibitors, some of the new tenofovir-based regimens too. And the question is whether the tenofovir does it, or was it the older form. And for those who know Truvada versus Descovy, for Truvada, we know it has an effect that it lowers your cholesterol. And then when you give someone the new form with Descovy, it raises it. But the question is, does it raise it, or was it just tenofovir did something to lower it? So it's an ongoing debate we have. But yes, because when you put those lipids into the calculator that we do to get your risk, if you have lower cholesterol, it's going to lower your risk. Now, the one thing I always tell a patient sitting in front of me is, if they're in there, and I've had a couple that, we don't argue, we have a very discussion, and I just try to make them understand, if you come in and your cholesterol's 320, trying to just change meds and diet, you're not going to get the amount of reduction you really need. So at that point, you really want to consider going on therapy. But yes, so the short answer is absolutely, switching from certain drugs decreases lipid and lower your cardiovascular risk. Do you want to say anything about that, Pablo?
Yeah, no, I think that's exactly what it is. In some cases, you cannot change your medicine, because you are taking the medicine because you had a history of failure when in the very old days, when you were taking 2 pills instead of 3 pills, or because we were not selecting the right medicines. So you have a history of battle failure. You might need to be taking a protease inhibitor. But if you can avoid some medicines, it's that increased lipids is a good policy to decrease cardiovascular risk. And so it's something that you have to discuss with your doctors. I think the treatment has evolved so much in the last few years, and we have so many regimens that I think the new regimens are much more friendly with the lipids and with your heart. And that's something to keep in your mind. But it's not only the medicines, it's making sure that you have a healthy lifestyle, that you don't smoke, that you do exercise, and also that you take the right medicine that has less cardiovascular risk.
All right. Hello, Tiara. So this is a two-part question, one from Tiara and then Robert, I believe you tagged on to this. So Dr. Tabas, you mentioned that the guidelines may change and require people living with HIV to take both ART and statins after age 40. Will this be required for patients with LDLs within a normal range and a good cardiovascular history? And I think that was key from the study, but go ahead, Pablo. Yeah,
That's the key. That's the question, exact question the study asked. Yep. Is people with low LDLs that have good cardiovascular risk. If you're older than 40, according to this study, and I think the guidelines are going to have to follow this unless there is some surprise in the presentation. According to this study, you should be taking a statin. Whether you want to take it or not is up to you, but the guidelines are going to recommend that. Remember, we used to think, I remember in the early 90s, when we used to think it is the virus, stupid. So we think about HIV as just a viral disease. And that's why we focus so much on antivirals and everything. We have learned over the years that infections are not just the virus or the bacteria or whatever the cause is. It's also the inflammatory response from the individual. So in COVID, we learned that it was not just the COVID, it was the inflammation associated with COVID that was killing people and that was producing the pneumonia. And that's why for COVID, we take antivirals and also we take anti-inflammatories, we take corticosteroids, we take baricitinib. So any infection, any infectious disease is a combination of the bug and the host response. And HIV is no different. I think that is the big lesson from the REPRIEVE study, that we're going to have to treat the inflammation that is associated with the infection.
And I think I brought this slide up again because I think, we present a lot of data, but I think what's highlighted in red here really is the take-home point for right now. Among people with HIV, 40 to 75 on antiretroviral therapy, and the key is low to moderate risk, right? So this is not the person comes in who has high blood pressure, diabetes, cholesterol is 250, they smoke. We know that person's at risk. This is low to moderate risk. And a normal range LDL, which is your bad cholesterol, treatment with pitavastatin is effective and will prevent major adverse cardiovascular events. So that's really the take-home point. And that's what I think makes the study really even more unique than other studies, because it was that this person would not, in normal care, if this study had not been done, we would not put them on a statin. Right? We look for risk factors. So this study answered that. Robert asked, if so, how soon for the guidelines? I know when something like this comes up, and then I'll let Pablo take a stab too. When something like this that is really a game changer, they have, they schedule ad hoc meetings to discuss this and sometimes issue guidance. But again, I think, we have to wait we're going to hear the presentation this afternoon at 4. Then they're going to present it at the International AIDS Society in Australia in July, and it's going to be published at the same time. So I don't know what you think, Pablo, how soon?
Yeah, guidelines in general like to rely on published papers. So until there is a publication, because, when you submit something for publication, there is a thing that is called peer review. So people review and comment on the publication. So the guidelines will change, I think, in the fall, after the presentation is made, the publication is made, and then there is some time for digestion of the whole data set. And then I think the guidelines will change. Normally it takes 3 to 6 months for guidelines to be implemented. But this is coming, and this will be part of the guidelines for sure. This is going to be the topic of conversation in any HIV patient, any people with HIV meeting for the next year. But I think definitely in the next few months, everybody's going to be talking about this study and what are the implications, how we can improve access and making sure that everybody hears about this and start considering this as part of their treatment.
All right, this is a loaded question. So from Timothy, thank you, Timothy, for a question. Do you want to share more information on why antiretrovirals makes one tummy big? And what can we do to control that? Thanks. That is a $1 million question. I was around and so was Pablo. It's actually when I first got into practice, when we used drugs like Stavudine or D4T or Crixivan, and they produced different changes where we talked about what's it called, the lipodystrophy. We all talked about lipodystrophy, and people had buffalo humps, and there was a lot of talk then about abnormal fat deposition, where it will be all centered in your belly, central adiposity, and then in the periphery, your limbs, you would lose a lot of the fat, and so you could see people's veins. And I think now we see a little more of that with certain integrase inhibitors, and it's not everyone, right? It's not everyone we see, and that question still remains, why does that happen? I don't think we really have an answer yet. We do know in certain populations, female individuals who are Black, we know that's where you start to see that weight gain, but it's not everyone. So it's not every female I put on an integrase, and this is what makes it hard. They're individual factors. So, we struggle a little bit with this, but I agree. It's one of the most common complaints I get asked about is, belly fat, and what can I do about it? Because people are worried it's related to the antiretroviral therapy, and they sometimes view the antiretroviral therapy as bad. But we do know that the antiretroviral therapy prevents a lot of this stuff, and that's why this study was specifically people on antiretroviral therapy. When you take away antiretroviral therapy, it poses a whole different risk, but this is on that. I don't know if you want to add anything, Pablo. Pablo and I have been dealing with this weight gain and big bellies for a very long time. I don't know I think he's frozen. Oh, we lost him. He will come back. Let me take Tiara's question. Are you and Dr. Tebas attending an international conference in Brisbane? If so, will there be a webinar of the presentation? So I am definitely going to Australia to present a different study. Pablo, are you going to, we lost you for a second. Are you going to Australia?
I plan to attend virtually, not to go unless things change. It's too far away, but I would love to see. I will see the presentation for sure, and other studies. Bill, you have to present, so you have to go. So
20 some hours I have to go. Not happily, but I'm going.
I will. This is one of the presentations, and Bill presentation, by the way. He's not at liberty to tell about that, but that's an important results. I know that somebody asked the question about weight gain and a big belly, and I know that we talked about lipodystrophy years ago, but the class of integrase and maybe tenofovir and acrylamide, great drugs, has been associated with increased weight, particularly in Black women. In women, so we still don't understand why, particularly women of color are the ones that are gaining more weight associated with that class of drugs. It might be part of a return to health, so people are getting better. The HIV is being in control, and then your metabolism keeps going, and then you gain weight. But it cannot be just that, because it happens also in women. So there are some genetic predisposition probably. We're trying to learn, but we know it happens, and we need to do something about it. And that's where we're trying to figure out what to do about it. There are a lot of excitement about new drugs that are becoming available to treat obesity and weight gain. We don't know if they work in people with HIV, and we are going to do studies looking at that. Some people are switching medicines to see if that will decrease the weight gain. That's the kind of studies that we're doing at the present time for that.
There's one other question. This is going to be an interesting discussion. Thank you, Martha. A patient who has been on a stable antiretroviral regimen, should they change to a new regimen that benefits their cardiovascular risk in addition to taking a statin? There's been the ongoing question for years. I think I've learned, early on, because I did a lot of switching. I think that was what we all did. I think we did a lot of switching when people were on protease inhibitors, though, when people were on things where we knew there was really profound changes in lipids. Now I don't really change for lipids because I don't know what I would change to an inferior regimen. So I tend not to do it. But also I think a lot of the drugs that I use now are what we call lipid neutral, except for TAF, which you can get some elevation. So I tend not to switch a lot.
Yeah, I agree. I think the older we get, and Bill and I are of certain age now, I mean, me more than Bill, the more reluctant you are to do quick changes. I mean, I think the medicines are so incredibly good now that if you have a medicine that is working for you, and you're not having many side effects, I mean, if you have very high lipids, no question, I will switch the regimen. If you want to be on an injectable because you don't like to take a pill every day, I will switch your medications for sure. But if you're doing well and you're taking Odefsey, or you're taking Biktarvy, or you're taking dolutegravir and tenofovir, or I have some people on a tripla. They have been taking a tripla for 20 years, and when I tell them, would you consider a more modern regimen? No, doctor, I am fine with this. I don't push it. I don't push it. Younger doctors tend to push it more because I think is the nature of the thing. We have learned that when you get your drug that it was working for you, stick to it. And then we will treat any complications that might come. We are not a big pushers of switches. And we have done our first share of switch studies. I don't know. I mean, if things are becoming better, we have studies now that instead of giving medicines every day, give you medicines every week. So if a patient is interested, if somebody is interested in participating, we encourage participation in these kind of things. But all of those things have to be in very well controlled, very close follow-up, so to make sure that we keep the people suppressed, which is the most important thing.
It looks like there's one other question about a medication causing weight gain and then undiagnosed insulin resistance. I think, HIV itself is a risk factor for diabetes. But again, I agree, if you have patrons who have weight gain, that's on the pathway, right? So if you're gaining more weight, you become insulin resistant, pre-diabetes, and then diabetes. And really now, as Pablo mentioned, there's a big push with pre-diabetes. The problem is getting the drugs covered with injectable therapy. And the goal of diabetes used to be get the sugar down, and now the new guidelines are released for diabetes, and the goal is really to get weight loss, right? We know when you lose weight, you improve insulin sensitivity, you improve your blood sugar. And so, but the problem is the drugs are not covered, and that's another fight that everyone's working on. But I agree, this weight gain does contribute, and that's why we worry about people gaining weight, because weight gain turns into higher BMI, diabetes, high blood pressure, all the things you think about, high cholesterol, and all these are important risk factors for cardiovascular disease. And we know that HIV itself is a risk factor. So yeah, very important questions and very important things. Are there other questions? These are great questions. Thank you so much for asking. Don't see any other questions. Yeah, no.